it's a pleasure to meet you today, and it's my honor to give you a talk. I will tell you about my clinical experience and paper review on infantile hemangioma. So there are no company in a relation of COI. So leave it alone, it will go away is no longer a wide accepted management option for most infantile hemangiomas. In 2019, the American Academy of Pediatrics emphasized that early identification and monitoring of infantile hemangioma is essential to allow for timely treatment that can prevent medical complications or permanent disfigurement. The AAP recommends treating problematic hemangiomas ideally by 1 month of age.
From who we move on to why do we need to make a precise diagnosis of segmental hemangioma. The main reason is because it gives us a better idea about the risk of complication and the appropriate treatment. Generally, we divide hemangioma based on the depth of involvement from superficial, deep to mixed, or based on unifocal, multiple focal, segmental, and also is there any extracutaneous involvement, any localized side effect or not. For segmental hemangioma, they have a higher risk of getting mixed pattern and also higher risk of getting complication, including extracutaneous involvement. Based on a study by Anita et al. Have shown that segmental hemangioma have 11 times more likely to experience complication, 8 times more likely to receive treatment than localized unifocal hemangioma.
Maybe I would like to ask are we waiting for the next speaker or we can start
I think we can start our conversation now, our discussion. Yes.
Yeah, I think we can understand why pediatricians are not very keen to start treatment early because most of them are well trained by non-dermatologists. And many years ago, when it comes to oral prednisolone, we are not talking about 0.5 milligram per kg per day. Patrick, I think you can remember it's like 2 to 4 milligram per kg per day for
super high
6 to
dose
9
of
months.
the systemic steroid.
Yeah, inevitably all of them will end up with round face. And at that time, the threshold to start active treatment is really high. Before we start a treatment, we need to inform our super consultant, can I start or not? There are a lot of factors need to be taken into consideration. But with propranolol on board, I think we should lower the threshold, the bar, and start using the new guideline to help our patients. I have some patients, they come in with a lesion over the face. They say, the pediatrician said no active treatment. I said, do you want to carry this for the next 7 years? Whenever you walk out, another mother will say, what happened to your kid's face? And we know that the kids nowadays, by around 3 years, they already have a lot of cell recognition. A lot of them will have very sensitive psychosocial development as early as the first 3 to 4 years. Especially in the era, a lot of selfie, they know how they looks like, and they definitely will have a significant impact on the psychosocial development of the kids that carry a birthmark, although claim to be cell regressing over the next how many years. I believe most of you agree with my statement. Yeah.
So I'm also curious about the dosing because we know that as a dermatologist to make a good diagnosis for very simple hemangioma is very easy. So the problems for some of the doctors who are not quite familiar with the dosing, I want to know that the starting dose or how you titrate for a very simple patient. So I would like to have the comment from Kim Fon and Changkeun and share your experience. And Kim Fon first.
Oh yeah. I remember when we first started in 2009 somewhere, because first discovered was in 2008. We were still very skeptical about how to start it. And at that point of time, propranolol only used by pediatric cardiologists for many, many years. And suddenly, when we decided to start, we have to admit the patient. We start with 0.5 milligram per kg per day in 3 divided doses. We do an ECG. We monitor the BP, pulse rate, and glucometer before initiation. Then we give the dose every half an hour. We monitor for 4 consecutive half an hour. Then we increase the dose the next day, increase the dose next day. So all propranolol patients need to be admitted for 3 days, from 0.5 to 1.